10 speakers, so we will we are starting it. I would request our moderator to please track the time and tell when 7 minutes. At 7 minutes, he should tell the speaker that only 1 minute left. So it's 8 minutes each talk, and we will start. And first of all, who is Shahid Tarar? किधर है हमारे? वो इधर ही है। अच्छा नमाज पढ़ के आते हैं. Okay. So we'll start with the first speaker, Farah Huba. She'll talk about dermolipoma.
Dr. Paras जो हैं for dermolipoma.
Assalamualaikum, my respected seniors and colleagues. I am Dr. Paras and I am currently working as a senior registrar right now in Avicenna Medical College, Lahore. Today I will be presenting my talk on dermolipoma. The salient features of this lesion are that it is a congenital choristoma formed by sequestration of ectoderm at the time of embryonic development. It is located mostly in the supratemporal fornix and mostly it is unilateral. Sometimes bilateral cases are also reported. It looks like a yellowish white, soft and smooth mass firmly adherent to the overlying conjunctiva. It is composed of adipose tissue, collagen tissue and skin adnexa which are covered by conjunctiva. This lesion may be contiguous with the orbital fat posteriorly and it can be adherent to the lacrimal gland or the underlying bone. It can occur sporadically or can be associated with syndromes like golden hair syndrome, organoid Nevers syndrome, Treacher-Collins syndrome. There can be other features of the eye such as colobomas. Osteomas can be related, limbal dermoids and facial nerve palsy can be associated. Mostly presentation of this lesion is in teenage, unilaterally, and most common there is female preponderance who come to you with aesthetic concern and foreign body sensation or inflammation, irritation by a lash growing out of the lesion, tear disruption, ptosis, astigmatism, strabismus, or lid contour distortion. The diagnosis is mostly clinical in this case, where we see a yellowish white mass in the temporal fornix which is not freely mobile and overlying conjunctiva is adherent to the underlying mass. This lesion, dermolipoma, cannot be deposited into the orbit. This is the differentiating point of it from the orbital fat prolapse. In the picture on the left side, you guys can see that there is an old person having bilateral lesion which is the orbital fat prolapse. If we try to do retropulsion test, then the size of dermolipoma will not increase or decrease, but the orbital fat prolapse will increase in size on retropulsion. We can also do imaging. Mostly the diagnosis is clinical, however, imaging can also be done. Imaging is done when we are planning for a debulking procedure. Here you can see on the rightmost picture, on the T1 weighted image, the yellow arrow is showing the crescent shaped lesion, which is hyper intense in T1 weighted and T2 weighted images and having the same signal density as the intraconal fat mass. However, it is not continuous with the intraconal fat and is being limited by the lateral rectus muscle. In the fat suppression imaging on the left side, on the left two slices, we can see that the lesion has become hypointense, just like the signal of the intraconal fat. We can also see that it is supratemporal to the globe and found anterior to the insertion of the lateral rectus on the imaging and medial to the lacrimal gland and not continuous with the intraconal fat. This point is important to note because the orbital fat prolapse cases are contiguous with the intraconal fat. The treatment is according to the symptoms. If the patient is asymptomatic, then we don't do any treatment. If there are mild symptoms of inflammation, then we give lubricants and anti-inflammatory agents. If the symptoms are severe, such as astigmatism and cosmetic concern or constant irritation, then surgical debulking is done anterior to the orbital rim and maximum conjunctival conservation is done. The bulk of dermolipoma is separated from the overlying conjunctiva as well as from the underlying tenon, and then that mass is excised. The desired outcome of surgery is maximum possible cosmetic and symptomatic improvement while preventing conjunctival contracture, symblephron formation, dry eye, or strabismus. Complications of the surgical procedure are as follows. Contracture of conjunctiva due to excessive cutting of conjunctiva. This will lead to strabismus. Damage to the lacrimal gland which may lead to dry eye. Damage to the lateral rectus causing strabismus. Ptosis because of damage to the lid. And insufficient debulking of the lesion, leading to dissatisfied patient post-operatively. Thank you.
I would like to invite Professor Sufia Iqbal for congenital anomaly of eyelids.
This is a huge topic.
Yeah, it is.
और 8 मिनट में आपने कवर करना है, ये कमाल करना है आपने.
ये कमाल तो करूँगी सर, लेकिन इसमें
बल्कि ये तो ये एक्चुअली सिंपोजियम की हेडिंग है क्यों.
So it means they were unfair to give me this topic, but let's see. It's a big topic, and we know that usually it's chromosomal abnormalities or environmental. I have classified it according to the position of eyelid, shape of the eyelid, and structure of the eyelid. There is danger to the health of the eyeball, so we have to act quickly. If we classify it according to just age of gestation, in 3rd to 5th month of gestation leads to cryptophthalmos and coloboma formation. 5th to 6th month of gestation will lead to anomalies like ankyloblephron, congenital ectropion, congenital atropion. After 6 months of gestation will result in euryblephron, which is horizontal widening and lateral canthal malposition, as well as telecanthus and ptosis. These are the other two problems, epiblephron and dystichiasis. Dystichiasis is an extra row of eyelashes which can be treated with epiliation, cryo and electrolysis. Cryptophthalmos will be discussed in more detail by the next speaker, but I'll just say that it is of different types, complete one and incomplete one. The previous picture was the complete one where the skin was continuous with the forehead and cheek. The abortive type is the one in which there is a normal lower lid and a normal varying degree of lateral part of the upper lid, and Fraser syndrome when it has got different systemic abnormalities. Reconstructive effects are useful in abortive type, but usually the prognosis is visually poor. This child has been to everybody and he just didn't tell me that he was operated before. So we did a mustard lid switch flap in this child, and afterwards we were able to save the globe to some extent. He is now on the list for keratoplasty. Coloboma can be associated with syndromes and isolated as well. Small can be treated with lubricants, and if it is bigger one, then this picture is that of Dr. Zafar's presentation, a small coloboma which was directly closed. And we can do a tensile flap where the defect is more than 35%, as in this child, tensile flap, and this is pre and post-op. This child was treated with a Cutler bed procedure, and this child actually was not a patient. She came with our attendant Afghanistan, and we operated on her, and we were able to do some functional restoration. Epiblephron is an extra row of skin and usually confused with entropion, and this was a pre and post-op in which we excised a skin and a strip of orbicularis from the lower lid. Euryblephron is a generalized enlargement of palpebral aperture, usually correction by lateral canthal tightening and tarsorrhaphy and skin grafting. These are two of our patients. The lower one, the female patient, has been operated recently, and lateral tarsorrhaphy was done by one of our fellows. Telecanthus, as we all know, can be a part of a syndrome. Usually it's the blepharophimosis syndrome with a lot of other problems like ptosis, epicanthus, and we first need to correct the epicanthus, telecanthus, ptosis, and sometimes ectropion. These are the means by which we correct the epicanthus, YV-plasty and Z-plasty, and telecanthus, usually by the medial canthal tendon shortening. This patient was treated by medial canthal tendon shortening and double Z-plasty plus autologous facial atta sling. So this is pre and post-op. This on the left side is the father who was treated at HMC, and now it is the son, and this was the daughter, and we did all procedures in one go, the ptosis as well as the epicanthus inversus and telecanthus, everything was done in one go. Ectropion is rare, usually part of syndromes, but treatment is just like skin grafting, horizontal shortening. This is the commonest abnormality which we all come across. Congenital one can be isolated, can be a part of superior rectus weakness as well as blepharophimosis. The two commonest performed surgeries are the levator resection and the frontalis suspension. So this child had bilateral ptosis, and you can see from the hairstyle which got better once he was operated with autologous fascia lata. Another child with a 2O proline, and this was a levator resection bilaterally performed. Now this is a grown-up man. This child, one of the first cases I did, and this is bilateral congenital ptosis. Again, it was a she was operated for sling, but then we operated autologous, dissection. So this was my last patient which we operated last week. This is the pre-op and post-op. So the take home is that they are all very common congenital eyelid defects. We all come across them, but they required urgent intervention because the vision in the globe is threatened. So reconstructive efforts may be fruitful in conditions like crypt ophthalmos. Even after multiple attempts, it's very challenging to treat that. So I think the next speaker will take it. And my last slide will be, mistakes are a proof that we are trying, and keep trying until you get it right. So let's invite you to our Peshawar ophthalmo, and I'm sure I have finished in time.
Yeah, that's really great. And
You have finished in 5 minutes only.
yeah, that's great.
That's great. Only 5 minutes. You have summarized. Okay, that's a wonderful. Okay. Next speaker will be Professor Ibrar Hussain for tumor registry in ophthalmology.
Bismillah ar-Rahman ar-Rahim. Now, Dr. Sophia का जो time है वो मैं लूँगा sir. Sorry. I've got two presentations. The first one is a little bit longer and the other is short. So bilateral, when I combine the two, it will be not more than 16 minutes, inshallah. Now, first is the eye cancer registry. It's a little bit different topic, and I would like to involve you in this for some time. Now, cancer registry, what is cancer registry? Is an information system designed for collection, management, and analysis of data on persons with diagnosis of malignant or neoplastic disease. Now, in developed countries, they have a registry in which all those cancer patients are registered. Now, there are three types of registries. Healthcare institution registries, where in one institution they will register their cases in detail, each case in a detail, but it's located and limited to only that institute. Then central registries, these are important. These are population-based registries in a geographical area. And then the special purpose registries, for example, we take one tumor and take the detail about that tumor. So these are three types of different registries. Now, what are the informations? There are different informations can be collected. Now, demographic information, medical history, diagnostic findings, cancer therapy, follow-up, and patient status, these are usually the part of institutional registries. Then why to maintain a registry? Accurate and timely information while allocating resources. Then to make important public health decisions, research, and then accurate survival information, which is a part of the follow-up of cancer patients. Now, this is the history. You see, in developed countries, in 1926, first hospital registry at Yale, New Haven Hospital. Then in 1935, first central cancer registry in Connecticut. Then in 1946, first central cancer registry in California. So we are more than 100 years behind. Then even in our neighboring country, India, it started in 1981, National Cancer Registry Program. Now what about Pakistan? In 1994, Shaukat Khanum Memorial Hospital and Research Center, they started registry, but it was an automatic registry because it is a cancer hospital, so all the record is maintained. So there is institution, at least it's an institution-based registry, you can say. Then in 1995, the Karachi people, they tried Karachi Cancer Registry. It was a registry only limited to Karachi South. So it was only involving one district of Karachi. Karachi has got, I think, 5 districts. So only one district was covered in that registry. Then in Aga Khan University Cancer Surveillance for Pakistan, in 2000 they developed a registry, and that is depending upon the biopsies which come to them, to their laboratories, and on that base they have maintained a registry. Now, keeping this thing in mind, I developed a website where I started putting those cases, and this is a generalized registry. First, it is on the name of icancerpk.com. So initially I started as icancerkpk.com. Then later on I expanded it to whole Pakistan. Now, I would like here you to open this in your mobiles, please, if you can. अगर आप icancerpk.com खोलें, क्योंकि मैं चाहूँगा कि आप लोग इस पे रजिस्टर हो जाएं, और रजिस्टर होने के लिए 2 मिनट्स एक्स्ट्रा चाहिए होंगे. You just open icancerpk.com. हो गया? खुला है किसी का? अच्छा, इफ़ यू सी उसमें बैक में आप जाएं तो ऊपर 2 वो लिखे हुए, एक साइन इन है और एक रजिस्टर है. जो रजिस्टर नहीं है, बाज़ लोग आप में से पहले से रजिस्टर हैं तो उनको नहीं, लेकिन जो लोग रजिस्टर नहीं हैं वो रजिस्टर का अगर बटन दबा दें, अगर आप रजिस्टर दबाते हैं तो आपके पास ये आ जाता है. चलिए, जिनका हो रहा है वो कर लेते हैं, क्योंकि टाइम इतना नहीं है. सिर्फ मैं रजिस्टर आपने प्रेस किया तो ये वाला विंडो खुल गई. इसमें देखें, जो लोग रजिस्टर नहीं हैं वो अपना नेम डालेंगे, सेल नंबर डालेंगे, यूज़र नेम और पासवर्ड डालेंगे, अपना जो भी डालना चाहते हैं, और कंफर्म पासवर्ड ये डालें और रजिस्टर का बटन दबा दें. ठीक है, जिन का हो गया है ये मेरे पास आ जाएगा सेंटर के पास. आई विल अलाउ देम, जो भी हैं हम उनको अलाउ करेंगे तो आप रजिस्टर हो जाएंगे. उसके बाद नेक्स्ट फिर ये होगा, बस दैट्स इट. आपने बाद में भी कर सकते हैं, लेकिन जिनका हो गया वो इस तरह है. ठीक है जी, यहाँ पे आप रजिस्टर हो गए. अब आप जो है लॉगिन पे जाएंगे. अब आप रजिस्टर हो चुके हैं जो लोग, वो लॉगिन पे जाएंगे. बस आप अब करने की ज़रूरत नहीं है, ये फिर आप बाद में करेंगे. लॉगिन पे जब आप जाएंगे तो आपके पास आपका यूज़र नेम यूज़ करें, पासवर्ड यूज़ करें और लॉगिन कर लें. लॉगिन हो जाएगा तो फिर आपके पास जो है ये दोबारा खुलेगा. उसमें फिर पेशेंट रजिस्ट्रेशन पे आप जाएंगे. पेशेंट रजिस्ट्रेशन, उसमें ऊपर लिखा हुआ है न्यू पेशेंट. ये न्यू पेशेंट है. आप न्यू पेशेंट को प्रेस करेंगे तो ये जो है डेमोग्राफिक डेटा है पेशेंट का. मैंने कोशिश की है कि बहुत ही सिंपल रखूं टू स्टार्ट विद. सिर्फ डेमोग्राफिक डेटा है, और जो है जो टाइप ऑफ कैंसर्स हैं वो हैं. तो इसमें डेमोग्राफिक में आप एज, जेंडर वगैरह ये लिखेंगे. इसमें एक चीज़ इंपॉर्टेंट है, क्योंकि इसको हमने दोबारा भी खोलना होता है कभी, तो पेशेंट का या तो सेल नंबर होना चाहिए या जो है वो आईडी कार्ड होना चाहिए, आईडी कार्ड नंबर होना चाहिए. दोनों में से कोई भी हो तो ये इसको एक्सेप्ट करेगा, और दोबारा इसको अगर आप खोलना चाहते हैं उस पेशेंट की डिटेल के बारे में तो खुल जाएगा. तो इसमें चूँकि CNIC मुश्किल होता है, लोगों के पास उस वक्त कार्ड होता नहीं होता, लेकिन एटलीस्ट सेल नंबर सबके पास आजकल है, या उसके अटेंडेंट होगा कोई उसके साथ, तो वो आप लिख लें ताकि दोबारा आप खोलना चाहे तो वो खुल सकती हो. अच्छा, ये जो है नेक्स्ट आ जाएगा. कि आगे इसमें आप देखें तो पिछले उसमें देखें, 1 2 3 4 5 6 7 8 9 10 11 12 13 14 15 16 17 18 19 20 21 22 23 24 25 26 27 28 29 30 31 32 33 34 35 36 37 38 39 40 41 42 43 44 45 46 47 48 49 50 51 52 53 54 55 56 57 58 59 60 61 62 63 64 65 66 67 68 69 70 71 72 73 74 75 76 77 78 79 80 81 82 83 84 85 86 87 88 89 90 91 92 93 94 95 96 97 98 99 100 101 102 103 104 105 106 107 108 109 110 111 112 113 114 115 116 117 118 119 120 121 122 123 124 125 126 127 128 129 130 131 132 133 134 135 136 137 138 139 140 141 142 143 144 145 146 147 148 149 150 151 152 1 آپ کے پاس سیل نمبر کے بعد نیشنلٹی ہے, وہ آپ پریس کریں گے تو پاکستانی. میں نے 2 ڈالی ہیں کیونکہ افغانی پیشنٹ ہمارے پاس بہت آتے ہیں, تو افغانی اور پاکستانی. ہم پاکستانی کو لیتے ہیں. جب پاکستان کو آپ پریس کریں گے پھر تو آپ کے پاس جو ہے یہ چیز آ جائے گی. یہاں پہ آپ کے پاس پروونسز آ جائیں گے. اس میں سے آپ پھر پروونس کو, مثلاً وہ پیشنٹ جو ہے وہ جس پروونس سے بھی ہے, آپ سارے پروونس اس میں آلریڈی ایڈڈ ہیں. پنجاب ہے تو پنجاب کے ساتھ ڈسٹرکس, سارے ڈسٹرکس ایڈڈ ہیں. تو آپ جو بھی دبائیں گے وہ ڈسٹرکٹ الفابیٹیکلی اس میں دیکھ لیں اور وہ ڈسٹرکٹ کو پریس کر دیں. تو یہ فلاں ڈسٹرکٹ سے یہ بندہ ہے, یہ ہمیں پتہ چل جائے گا کہ پاکستان کے کس صوبے سے اور کس ڈسٹرکٹ سے ہے. پھر جو ہے ٹیومر انفارمیشن, جو اس کو کینسر ہے, میں نے آئی کے 5 اس میں اس کو ڈیوائڈ کیا ہوا ہے. ایک جو ہے لڈ اینڈ ایڈنیکسا ہے, پھر آکولر سرفیس ہے, پھر انٹرا آکولر ہے, پھر جو ہے انٹرا آربٹل ہے, اور اس کے بعد جو ہے ادرز میں جو ہیں آپ کی جو ہیں دوسرے جگہوں سے ٹیومرز آتے ہیں, میٹاسٹسز وغیرہ وہ آ سکتی ہیں. ٹھیک ہے, تو اس میں آلموسٹ 90% 95% ٹیومرز کور ہو جاتے ہیں جو جو آئی کے ہیں. اچھا, اب دیکھیں اس کے اوپر اناٹومیکل لوکیشن آف ٹیومر, تو فرض کا لڈ پہ ہے یا نیچے دیکھیں آکولر سرفیس ہے, انٹرا آکولر ہے, جو بھی ہے آپ اس کو پریس کریں گے. جب پریس کریں گے اب جو ہے آکولر سرفیس ہم نے اس میں سلیکٹ کیا ہے, فرض کیا. اب دیکھیں آکولر سرفیس میں کنجکٹیول اسکویموس سیل کارسینوما ہے, اس کے علاوہ جو ہے وہ میلیگننٹ میلانوما ہے, کنجکٹیول لمفوما ہے, اور کنجکٹیول کیپوسی سارکوما, اور ادر ساتھ لکھ دیے, مطلب مینلی کور ہو جاتے ہیں اس میں سارے. تو جو بھی ہو آکولر سرفیس وہ آپ کلک کریں گے. مثلا OSSN کا پیشنٹ ہے اور آپ جو ہے اس کو کنجکٹیول اسکویموس سیل کارسینوما کو پریس کر دیں گے. اس کے بعد جو ہے اگر آپ دیکھیں تو کچھ اور وہ بھی ہیں, وہ اتنے امپورٹنٹ نہیں ہیں. بایوپسی رپورٹ ہے, شروع میں ہم کہتے ہیں کہ یہ BCC ہے, فرض کیا بایوپسی رپورٹ 10 دن بعد آتی ہے اور وہ کہتے ہیں کہ نہیں یہ تو اسکویموس سیل کارسینوما ہے, تو آپ اس ونڈو کو دوبارہ فون نمبر سے کھول سکتے ہیں, اس پیشنٹ کی ڈیٹیل اور ڈائگنوسس کو چینج کر سکتے ہیں. پھر جو ہے باقی 2-3 چیزیں ہیں, وہ اگر فل نہ بھی کریں تو اس سے کوئی فرق نہیں. ریفر ٹو کہاں اس وقت میں نے اس میں ڈال دیا تھا, لیکن آل پاکستان پہ یہ تھوڑا مشکل ہے. یہ KPK پہ ہم نے لکھا تھا, چاند ہاسپٹل سے ان کے نام لکھے تھے, تو یہ اگر آپ نہ بھی کریں تو یہ آپ کو ایکسیپٹ کرے گا. صرف یہاں پہ نن لکھ دیں گے آپ. اور اسی طرح فالو اپ ہے, فالو اپ میں بھی نن لکھ دیں, یا فالو اپ کے کچھ وہ ہیں بھی اس میں. اس کے بعد ایک اور ونڈو نیچے لکھے میسج ریگارڈڈ دیٹ پیشنٹ. مثلا وہ پیشنٹ آپ جو ہے ایک جونیئر ایک سینئر کو ریفر کر رہا ہے اور وہ اس کو کہہ دیتا ہے کہ میں نے یہ کیا ہے اور آپ سے میں اس کی وہ چاہتا ہوں کہ آپ ایکسپرٹ اوپینین دے دیں, تو وہ بھی اس میں آ سکتا ہے. دین یو سبمٹ اٹ, سبمٹ, تو سبمٹ کریں گے تو یہ میرے پاس آ جائے گا, جو سینٹرل ڈیٹا ہے اس میں ساری چیزیں ہو جائیں گی. سو دس از اے اسٹارٹ آف رجسٹری. ٹائم کتنا ہوا ہے جی؟ اچھا پھر خیر ہے نہیں ختم ہے یہ انشاءاللہ, بس جو بیسک چیزیں میں نے بتا دی. یہ جو ہے ایگزسٹنگ پیشنٹ جو میں نے بتایا نا کہ آپ دوبارہ بھی پیشنٹ کو وہ کھول سکتے ہیں, تو آپ دیکھیں اس میں لکھا ہوا ہے ایک نیو پیشنٹ ایک ایگزسٹنگ پیشنٹ. تو ایگزسٹنگ پیشنٹ کو اگر آپ دبائیں گے تو یہ آ جائے گا. اس میں آپ اس کا فون نمبر لکھیں یا CNIC لکھیں اور وہ کرتے ہیں پریس کریں تو وہ دوبارہ اس کی ڈیٹیل آ جائے گی اس پیشنٹ کی.
سر آپ کے پاس 3 منٹ ہیں ابھی.
اچھا ٹھیک ہے جی, دیٹس اٹ, بس یہ ختم ہو گیا. یہ سو ڈیٹا انالیسس ہم کر سے, بس صرف میں اس پہ تھوڑا سا بتاتا ہوں پھر ختم کرتے ہیں. ڈیٹا انالیسس یہ ہے کہ یہ دیکھیں اس میں اگر آپ چاہتے ہیں کہ فلاں ڈیٹ سے فلاں ڈیٹ تک پشاور سے OSSN کے کتنے کیسز رپورٹ ہوئے تو وہ آپ کو دے دے گا. اسی طرح اگر آپ چاہتے ہیں کہ صدیقی صاحب نے کتنے کیسز جو ہیں وہ سال میں کیے تو وہ جو ہے وہ سارے ہو جاتے ہیں. تھینک یو. تو یہاں پہ ہم جو ہے مختلف کمبینیشن سے ڈیٹا جو ہے پھر نکال سکتے ہیں. تھینک یو ویری مچ. تو یہ میں چاہوں گا کہ اس پہ آپ کام کریں تھوڑا سا, جو لوگ کر سکتے ہیں, کیونکہ ہم چاہتے ہیں کہ یہ ڈیٹا ہمارے پاس آ جائے. نیکسٹ کر دیں. سو ایپیبلیفران تھوڑا سا تو پروفیسر صوفیہ نے بتا بھی دیا تھا, لیکن اس میں تھوڑا سا ہم جاتے ہیں آگے. ایپیبلیفران ان ٹرننگ آف دا آئی لیشز, in presence of normal eyelid position. دیکھیں انٹروپیان سے اس کو ہمیشہ کنفیوز کرتے ہیں ہم, اور انٹروپیان سے سیپریٹ کرنے کے لیے یہ ہے کہ انٹروپیان میں جو لوور لڈ ہے وہ ٹرن ہو جاتی ہے اور اسی پوزیشن میں رہتی ہے, اس کی پوزیشن ہی انٹرنڈ ہوتی ہے. اس میں جو ہے وہ ٹیمپرریلی انٹرن پوزیشن ہوتی ہے ڈیو ٹو پریزنس آف ایکسٹرا فولڈ ان دا اسکن. یہ اپر میں بھی ہو سکتا ہے, ہم تو لوور میں اکثر دیکھتے ہیں, بٹ اٹ از پاسبل ان دا اپر لڈ ایز ویل, جو کہ بہت ریئر ہے لیکن اپر میں بھی ہو سکتا ہے. سو عموماً جو ہے کنجینیٹل ہوتا ہے, اور ایشین جو فیشیز ہیں چائنیز اور یہ اس طرف والے, ان میں زیادہ ہوتا ہے. اور اٹ کاز کنٹینیوس ٹچنگ آف دا آئی لیشز ٹو دا کارنیل سرفیس, اینڈ اس کی وجہ سے ربنگ اور ریڈنس اور یہ چیزیں رہتی ہیں. آل دو ان اسمال چلڈرن بیکاز آئی لیشز آر سافٹ, تو یہ زیادہ تر پرابلم نہیں کرتی, لیکن اگر کریں تو دے کین کاز irritation and continuous rubbing, even ulcer can be formed. یہ ایپیبلیفران ہے, اگر آپ دیکھیں تو یہ اسکن فولڈ ہے. دس از دی کلپریٹ وچ از کازنگ دی انٹرننگ آف دی آئی لیشز. کلینکل فیچرز ہم نے ڈسکس کر لیے. یہ جو ہے آپ جب اس کو اسٹین کریں گے تو پھر آپ کو جو ہے وہ جو مائنر چینجز ہیں یہ کارنیا کی, وہ اس سے آپ کو پتہ چل سکتا ہے. Treatment, mild cases, just observation. As I told you that the lashes are soft in small children and it is usually seen in children. تو کیونکہ جب ایڈلٹ ہو جاتے ہیں تو یہ فولڈ آٹومیٹیکلی بہت سے لوگوں میں خود ہی ختم ہو جاتا ہے, تو اس لیے آپ جسٹ آبزرو کریں, اور اگر کوئی تھوڑی بہت اریٹیشن ہے تو آپ ان کو لوبریکینٹس ڈراپس دے سکتے ہیں. Now these are different hyaluronic gel injections. Sometime temporarily it will turn the eyelids outward. Similarly, botulinum toxin, sometimes it has been used. Severe cases, surgery is done, and that's called host procedure. Surgery involves removing of a small area of excess skin and muscle just below the lid margin and then suturing the wound. This helps the lashes to rotate outward. یہ ہے ہوسٹ پروسیجر میں. آپ دیکھیں اس میں ایک بس صرف ٹرک یہ ہوتی ہے کہ یہ آپ نے یہ کیس ہے, یہ آپ نے مارک لگایا, یہ آپ نے ایک کریسنٹ شیپ جو ہے وہ فولڈ اسکن جو ہے ہٹانی ہے. وین یو ریموو دا اسکن دین آفٹر دیٹ یو ہیو ٹو ریموو دا اسکن ایز ویل ایز انڈر لائنگ مسل, اینڈ یو ہیو ٹو ریموو دا اسٹرپ فرام دی لوور پارٹ. یہ اسٹرپ آف مسل ایکسٹرا بھی آپ نے ہٹانا ہوتا ہے. دین یو ری سوچر اٹ, اینڈ سوچرنگ میں یہ کرنا ہے کہ یہ جو اپر اینڈ ہے کریسنٹ کا, اس کو جو ہے وہ ٹارسل پلیٹ کے ساتھ پہلے کچھ سوچر سے فکس کر دیں, اور پھر اس کے بعد جو ہے وہ اسکن کی سوچرنگ کر لیں. سو دس ول ایورٹ دی آئی لیڈ. یہ ایک دو کیسز ہیں جو ہم نے کیے ہیں, جن کا ریکارڈ ہمارے پاس ہے. یہ دیکھیں ایپیبلیفران دونوں آنکھوں میں, دس از ڈیورنگ اینستھیزیا اینڈ دس از آفٹر ایٹ دا اینڈ آف دا سرجری. اس میں دیکھ لیں, یہ نیکسٹ ڈے پہ آپ دیکھیں تو ایورٹ ہو گئی لیٹس. تھینک یو ویری مچ.
Okay, that's great.
Thank you, sir.
Shahid Taro.
Dr. Shahid Tarad for crypt ophthalmos.
This horse procedure, you have to be careful not to overdo it, otherwise it will lead to ectropion. So that you have to just grasp the skin and measure it.
Bismillah ar-Rahman ar-Rahim. So let's talk about dry subject after interesting topics. So cryptophthalmos is a rare congenital anomaly, and it is about 1 in 2 lakhs in live births. 2 lakhs live births, one case. It's so much rare. So it has 3 main types: complete, incomplete, and abortive. So being oculoplastic surgeons, most of you I'm sure have seen these cases and managed, the senior consultants have managed these cases, and for trainees to be aware of this issue and then either manage or refer them to some oculoplastic surgeon. So incomplete, basically in cryptophthalmos, there is problem with the eyelid folds during the intrauterine life. And the forehead skin is continuous over the eyeball up to the cheek. This eyebrow structure is usually absent. And in sphere forms, there is microphthalmos as well. In incomplete, you can see the medially, the eyebrows are less marked. Upper eyelid is almost 80% is deficient. This is the abortive type. Some may, you can say it is the extended form of symblepharon. But definitely it is different entity. Don't confuse these two terms. Now this is Fraser syndrome is autosomal recessive disorder which is associated with cryptophthalmos. Basically, cryptophthalmos is ophthalmic association of a systemic syndrome, mostly. So either two major or one minor criteria or one major and four minor criteria should be there to label as Fraser syndrome. Now, what are the major criteria? Cryptophthalmos. So 90% chance is the newborn will be presented to a ophthalmologist, to eye specialist. From pediatrics, they will come to you people, to the ophthalmologist. And now you are the one to look for the other systemic associations. Syndactyly, 77%, abnormal genitalia, siblings with the syndrome, there will be more chances. Now the minor criteria, congenital malformation of the ear, nose, larynx, cleft lip, skeletal defects, umbilical hernia, renal and mental retardation. So these are the other associated features which can be there. Now the management is different depending upon how much is the severity and what is the tissue left and what about the eye globe. So that is basically case to case variable. There is no clear cut like 2 and 2 makes 4. It is not, answer is not like that. So management depends upon the visual potential and the defect size. Multidisciplinary approach, definitely the systemic involvement. Whosoever specialty, especially the gentry, urinary people, they are the one to look for the this systemic, and you can involve the pediatric ophthalmologist or pediatrician. So to look for the systemic associations. Now the surgical, what are the options? Myocutaneous flap could be there, and then the cutler beard is the another, because mostly the upper eyelid is involved. We talked about this. This is the cutler beard. One of the approach to manage this, you all are familiar with this cutler beard flaps. The second is with which I managed. This is the baby girl presented about 4 years back to me with this much tissue loss. You can see the eyebrows, the forehead skin is continuous and the eyelid margin is attached to the cornea. Now important is there were some delayed milestones and undescended testes. So that was association in this child, and ambiguous genitalia. Keep in mind her initial name was female child. Some name was on the females. With the passage of time, so first of all is to save the eye globe and the cornea, to there should be no damage to the cornea. That is the challenging in the newborns. So luckily her mother was educated, So initially I had to call on alternate days, and once I noted that she can manage very well, there is no exposure of the cornea, then I followed this child weekly basis. So when the age was 1 year plus, we planned for surgery. So here you can see the upper eyelid fold is directly attached to the corneal at below the limbus. Here you can see this one. So the attachment of the skin was up to here, almost upper 40% of the cornea was covered with the skin. So you need to dissect it and release the tissue, okay? And what next? If you just reattach this tissue, there will be adhesions again. So next was
1 minute left, please.
Sir?
You have got one
Okay.
more minute.
Okay, sir. So this is the amniotic membrane. Basically, you cover the amniotic membrane and you cover all the cornea and make the superior fornix. This is very much important. If you are not making it, the surgery will be failed, definitely, because there will be exposure later on. So this is the result. You can see the scar, pre and post-op. अब सर ये कंप्लीट कर लेने देनी आपने. So you can see the lid closure. Okay, the lid closure is complete. If the adhesions are not properly released and superior fornix is not formed, then there will be exposure. Thank you very much.
Planning a challenging lid construction. Actually, I just can't, which the presentation I made just doesn't justify this symposium. It's congenital eyelid malformation, etc. So I've changed it. I will quickly go through the cryptophthalmos. Okay, this all has been nicely described by the Shahid. I will come to surgical side, and this is one of the patient, and this is about 60% defect. I've seen that if you do, I mean, in a smaller defect you can go ahead with the tensile flap, but with the larger defect you have to do Cutler beard, which Shahid mentioned. But my preference is actually mustardial lid switch flap. That I will that I have made a flap of inferior lid, and luckily in these patients, not only inferior lid is normal, but it's a bit elongated. So you can get a good flap, and you just rectangulate the defect so that you can suture it in 3 layers, and then it is applied, and that you can see the difference of the cornea. Now you will get a nice this cornea is bit dry looking, but now it's a shiny cornea, and you can get a good dorsal plate and some eyelashes. Later on, when you grow up, you can transpose the later end of the eyelashes with skin onto here, onto the dorsal plate of this tissue. So this I have found much better than the Cutler beard procedure. This is another patient where bilateral tensile flap was done elsewhere, but it actually wounds opened up, and this patient presented with a lot of conjunctivitis, which I treated, and then I went ahead with the lid switch flap, and this was the final result. So I can't do that one, so I preferred over Cutler beard. अच्छा, जो मैंने बताया ना कि fraction that area and try to triangulate or rectangulate the defect, and then at the lateral end you make a flap of the lower lid, and the width should be 4 millimeter. And then you made a horizontal full thickness cut. And rotate that into the defect, and mind it that you have to suture in 3 layers and apply as many suture as possible. Otherwise it will tear up or suture, the wound may open, which you have created.
मेजॉरिटी सर 60% जो NWLP है वो कहते हैं कि नहीं
इसके पीछे आवाजें आ रही है, we are talking a lot. नहीं, वीडियो बंद नहीं करें, चलो लगा रहे वो वीडियो, फिर साउंड बंद करें. एनी हाउ दैट वाज फाइन. अब नेक्स्ट पे चले जाते हैं. अब ये आफ्टर 6 वीक्स आई एम ओपनिंग इट, और ओपनिंग करते हुए आपने जो अपर डिफेक्ट है उसको पेंटागोनल टाइप बनाना है, ठीक है. एंड देन यू सुचर द अपर डिफेक्ट. So the main aim of this procedure is to get a tarsal plate, a nice tarsal plate. Then you can do a lot later on when the child grow up. Now I am doing a tensor flap for the lower lid, and that will you can see there up there a nice results the next day. So my preference is this one. Most of the people are doing cutter beard, and if they get it, they can try it and they will be very, very happy behind it. Okay, I have another case of blepharophimosis, but I sacrifice for the sake of other presenters to come here. Thank you very much.
Thank you, sir. Now, Professor Tayyib Afghani Saab for rhabdomyosarcoma.
अस्सलाम वालेकुम. जी मैं भी फरमाने लगा हूँ कुछ. Bismillahirrahmanirrahim. Actually, I agree with Professor Zafar that the topics and the title of the session were not very much specific and compatible, but anyway, at the end of the presentation, I think you will find it a halal presentation. So I was given the topic of rhabdomyosarcoma, but I will be talking about a little bit, just a small segment of it. Well, it is an ocular emergency, there is no doubt, and it should be treated as such. And the objective is to highlight the urgency and accuracy in diagnosis of orbital rhabdomyosarcoma. Well, this is a saying which actually Albert Jacobi has put it in his book a lot of years back. If our rhabdomyosarcoma presents on Friday afternoon, and do not wait till Monday morning for treatment to start if you clinically suspect it. So it's such an emergency that we should put all our resources to save the. Yeah. It's a highly malignant tumor and is one of the few life-threatening diseases that present first to ophthalmologists, and the most common soft tissue sarcoma of the head and neck in childhood, 10% of all cases in the orbit. It has been reported from birth to 7th decade, with the majority of cases presenting in early childhood. I will show you our series at Al-Shifa. Survival changed drastically over the years, from 30% in 60s to 90% presently, due to new diagnostic therapeutic modalities. Tissue of origin is pluripotent mesenchyme. It does not most of the times directly arise from the extraocular muscles. Metastasis is relatively less common. Now, what are the myogenic tumors of the eye that we have seen at Al-Shifa? I classify it into striated muscle tumors and smooth muscle tumors. And striated muscle tumors, rhabdomyosarcoma, there were 37 cases over the last 20 years. And alveolar soft part sarcoma, there were 4 cases. Amongst the smooth, we have 1 case of leiomyoma of the gingiva that presented as pterygium, and we did not find any leiomyomas from other uveal locations. 37 cases of rhabdomyosarcoma of orbit, in the age range was birth to 23 years. So there is a touch that I showed you that rhabdomyosarcoma is congenital, can be congenital, and I will show you one of the congenital cases. And we have the maximum age is 23 years, average was 7 years, and gender is almost equal, 18 male and 19 female. Histopathology, and more than 90% were embryonal, and then few were alveolar and spindle cell. Management is of course excision, chemotherapy, and some cases radiation as well. So what are some of the problems that can mimic as rhabdomyosarcoma, or rhabdomyosarcoma can mimic as those? So this child presented with this, we can see this, you can see can I show you? There is, yeah, like this, sudden proptosis. Parents were scared, we were anxious. This is this was the on CT scan, but fortunately, no, it was close to that. This was what we withdrew. There was no history of trauma, and finally, after a couple of years and one more surgery, she is the child. It was a lymphangioma, chocolate cyst, where suddenly hemorrhage developed into that, and that it does happen sometimes that it can be confused with rhabdomyosarcoma. Another is that child presented elsewhere as and treated as elsewhere as orbital cellulitis, but further clinical evaluation and surgery at our place resulted in this. And this is when this was a 3 months child, and probably it also started close to birth. Now we followed it up for 5 years after undergoing chemotherapy and surgery. He is doing well. Now congenital rhabdomyosarcoma, because this is a session for congenital problems, so that's why I'm saying that you will find it that I will justify my topics orientation. This is a patient presented this like this. I am not showing you the patient child itself. I have the picture, but actually it's difficult to see sometimes. This is calcification and all that. This is all, the tumor at birth, a huge tumor in fact. This is after it was cleaned, and the tumor was, and the cornea was already gone, and then we did the surgery. You can see after the surgery we were able to salvage the eyeball, the muscles were intact, but the tumor and all these were redundant by the time we removed it. The muscles had lengthened. So that's how we removed it, but unfortunately the child did not survive after 6 months, because it was too early to start chemotherapy, and the child died after 6 months. So current management of rhabdomyosarcoma is multimodal. It's surgery plus chemotherapy to control disease spread, even if there is no metastasis, because most patients have been found to have some micro metastasis in studies. Radiotherapy is used to treat the most high intermediate risk patients. Future management, there are research is going on, novel therapies like oncolytic viruses, immunotherapies, dendritic cell vaccines. In addition, evidence suggests that some targeted agents, maybe these, including proteasome inhibitors and IGFR antibodies. The role of oral maintenance therapy may be useful in controlling metastatic disease instead of IV chemotherapy, but yet it has not been confirmed. It is under investigation. In conclusion, rhabdomyosarcoma is an ocular emergency. No delay is acceptable. Acute onset mimics lesions like chocolate cyst, orbital cellulitis, or vice versa. Surgery and chemotherapy, where I have supported VAC as vincristine, actinomycin D, and C is for cyclophosphamide. These are the 3 chemotherapeutic agents that are mostly used. These are the mainstay. And at Al Shifa Trust Center for Eye Cancer, we are providing chemotherapy to all the patients who need it with ocular cancer free of cost. Thank you very much.
Our next speaker is my great teacher, Professor Amir Yaqub. He will be enlightening us about the orbital granulomatous inflammatory disease.
आई थिंक इस सेशन में आई थिंक द सबसे हराम प्रेजेंटेशन मेरी है बिकॉज इट हैज एब्सोल्युटली नो रिलेशनशिप टू व्हाट द रेस्ट ऑफ द प्रेजेंटेशंस आर. So anyway, I try to keep it simple, and it's a heterogeneous group of conditions which present in the orbit as granulomatous inflammatory diseases, and I've tried to keep it simple and keep it short so that it's just an introduction for the trainees what these conditions are. So it's a group of conditions that cause granulomatous inflammation in the orbit. And what are granulomas? Granulomas are small clusters of immune cells which have morphologically undergone a change, and they appear more like flatter cells, and they are called epithelioid cells. So epithelioid collection of epithelioid cells in any condition will bear its name as a granulomatous inflammation. Now these can lead to significant visual impairment and other ocular complications if they're left untreated. What are the main risk factors or main causes of this type of inflammation in the orbits? Firstly, infections. Out of these, I think fungal are the most important, which can cause granulomatous inflammation. More commonly, it's the autoimmune diseases which cause granulomatous inflammation in the orbit, and these include sarcoidosis, Wegener's granulomatosis, and other IgG4 related disease, which I'll talk about in more detail. In some cases, we don't find any cause of this type of inflammation. So common systemic conditions which cause granulomatous orbital inflammation include sarcoidosis, which can present in any part of the orbit. Also Wegener's granulomatosis, which can involve the sinuses as well as the respiratory system. Tuberculosis is the commonest infective cause of granulomatous inflammation in the orbit, and other non-infectious causes. Clinically, they present as a spectrum of idiopathic orbital inflammatory disease. So it can present in any part of the orbit, either interior or as a myositis, or as apical, or in intraconally or diffuse. So they usually present as with proptosis, pain, visual disturbances, as an orbital mass, especially because these granulomatous conditions are more subacute or chronic in course, or recurrent in inflammation. So they can present as orbital masses, and sometimes redness and swelling. In severe or long-term cases, visual loss and blindness can result because of the optic nerve compression and inflammation. A little bit about IgG4 disease, which has come up recently. It's an immune-mediated fibroinflammatory condition which results in tumor-like masses or, if left untreated, fibrosis of the involved organs. It can present in all parts of the body, including the orbit, and it mimics malignant infectious or inflammatory diseases. So IgG is, immunoglobulins are of five types, and we're talking about IgG. And IgG again has 4 subtypes, and in this condition involves the IgG4 subtype. Histopathologically, as you can see, these cells appear more epithelial-like, and they're collected in rounded shapes. So that is why it is called storiform fibrosis, and they result in obliterative phlebitis and fibrosis eventually. Treatment is with the steroids, or if they don't, you can even use direct injection, especially if it is limited to the lacrimal gland. If they don't respond to steroids, then immunosuppressive treatment with azathioprine is indicated, and in unresponsive cases you use rituximab. In these granulomatous conditions, you reach the diagnosis through all these various steps. Obviously, history and physical examination is important. Imaging shows various isointense masses or opacification of the various parts of the orbit. But I think biopsy is the key here, where you need to get an incisional biopsy and to get to a final diagnosis. For systemic conditions like sarcoidosis, tuberculosis, you can do some blood tests which can give you a help. Management strategies, as I said, include medical therapy, including corticosteroids, immunosuppressives, antibiotics in infective etiologies, and monoclonal antibodies like rituximab in autoimmune conditions. Surgical intervention is indicated if there are the orbital masses which are compressing the the optic nerve, or there is need for orbital decompression in severe cases of proptosis. And also you need to look for a systemic disease in the and if that is present, then you need to treat that. Complications include vision loss due to optic nerve compression. Recurrent inflammation is the hallmark of these conditions. Generally, they present subacute or chronic in course, and they present with remissions and exacerbations. Prognosis, generally, if you treat them early in the inflammatory stage, the prognosis is usually good. Sarcoidosis responds very well to steroids. Obviously, tuberculosis requires full treatment. And autoimmune conditions, prognosis depends on how you need to get the physicians involved as well. So in conclusion, orbital granulomatous inflammatory diseases are rare, but can have serious consequences if left untreated and not diagnosed properly. Early recognition, proper treatment can help prevent complications, including vision loss. Incisional biopsy is the key to the diagnosis of these conditions, and a multidisciplinary approach may be required for managing those with systemic problems. Thank you very much.
Thank you. Thank you, sir. I would like to invite Dr. Shafqat Ali Shah to present his 5-year audit on pediatric dermatitis surgery.
Bismillah ar-Rahman ar-Rahim. I am Dr. Shafqat Ali Shah, Associate Professor at Bacha Khan Medical College, Mardan. So this is my medical college and this is the hospital. So as you know that dermatitis cyst is a choristoma. So it arises from the surface ectoderm which has gone buried during the fusion of the mesodermal processes and keratinized squamous cell carcinoma, keratinized stratified squamous cell epithelium line these cysts. So dermatitis cysts, they occur everywhere and they constitute about 90% of the head and neck lesions, while in orbit they constitute about 3 to 9% of the lesions. So they are subcutaneous, smooth, painless, mobile and partially mobile swellings. So usually they are present along the frontozygomatic sutures, lateral orbital wall, frontoethmoidal and frontonasal suture at the medial wall of the orbit. So they can cause a complication which they can cause include extraocular movement abnormality and non-axial proptosis, decrease in visual acuity, erosion and remodeling of the underlying bones due to mass effect. They contain ectodermal appendages like hair, nails, and dental material. So they can be superficial to the orbital septum and deep into the orbit. So they can occur in the conjunctiva, cornea, and in the orbit. So limbal dermatitis usually are present at the inferotemporal quadrant of the cornea and conjunctiva, and they can cause astigmatism and amblyopia. So CT scan is must for the diagnosis as well as for the presence or absence of bony window and intraorbital and intracranial extension. So complete surgical removal is must along with the intact capsule to prevent recurrence. Excision should be given along the skin margin and care should be taken to avoid skin wrinkles. It can cause astigmatism and amblyopia. So this prospective study was conducted at Bacha Khan Medical College, Mardan from January 1, 2019 to December 2023. So during this time there was COVID-19 infection, so most of the hospitals were closed for almost 2-3 years. So the aim of this study was to see the gender-wise distribution of the dermis cysts, their location and surgical success in pediatric patient. All the patients were selected from the OPD and they were properly selected and all investigation were done and then surgery was carried out. So these patients, none of the cysts after surgery was sent for histopathological examination and no recurrence was found in the patient from 6 months up to 5 years. So dermis cyst was removed in 47 pediatric patients, 26 were male and 21 were female. Minimum age was 1 year and maximum age was 17 years. Maximum number of patients were 25 in the age group from 11 to 17 years, and the number of patients in the age group 1 to 10 years was 22. Dermis cyst was present on the right side in 27 patient cases, and it was present on the left side in 20 cases. There were 3 limbal dermites, and they were all present in the inferotemporal quadrants. So they were removed in block in 34 patients, and rupture of the cyst occurred in 10 cases. And there was no rupture of the cornea occurred in limbal dermite excision. So this is dermite cyst. So different patients. So result, there were 26 male patient and 21 female patient. Minimum age was 1 year and maximum age was 17 years. So right side involvement was in 27 cases and left side involvement was in 20 cases. So limbal dermite was present in 3 patients, 1 was male and 2 were females. And they were present in the right inferotemporal in the 1 eye, and in the left it was present in 2 eyes. So this is the location of the different dermite cyst in both eyes. So it was present above the medial canthus in 16 cases, center of the eyebrows in 7 cases, lateral end of the eyebrow in 17 cases, lateral to the outer canthus in 2 cases, and present below the lower eyelid in 2 cases. So this is the location of the dermite cyst in the right eye. So this portion is making the main mass of the cyst. So it was lateral upper eyebrow, and then it was followed by right medial canthus, and then lateral to the outer canthus, and then below the lower eyelid. In the left eye, dermite cysts were present above. In the 9 cases, it was present in the left upper medial canthus, and it was present in the lateral end of the eyebrow in 8 cases, and it was present lateral end of the eyebrow in 3 cases. So complication which occurred during surgery, so there was cyst rupture in 10 cases, and the rest, there were no significant complications. So superficial dermites are more common. Superiotemporal dermite were most frequent, followed by superionasal, followed by cyst at the center of the eyebrow, and least at the outside to the lateral canthus and below the lower eyelids. Limbal dermites were infratemporal. Nadeem et al. Has majority of the patient with limbal dermites, followed by superionasal and then superiotemporal. Kewaza et al. Has dermite cyst in the superiotemporal portion in 86% cases and 10% in the superionasal portion of the orbit. There were the same number of dermite cysts temporally and nasally with left-sided dominance in a study conducted by Sherman et al. So previously limbal dermoid was treated with shear excision, but now it is removed and the defect is covered with small incision lenticule extraction. So different surgeons have different methods of treating this limbal dermoid. Some use fibrin glue, some use amniotic membrane, and some use 10-0 nylon. Children with limbal dermoid are usually amblyopic due to high hyperopia and astigmatism. So after limbal dermoid excision, there should be patching and glasses should be properly prescribed. Amblyopia reduces after excision of the limbal dermoid. So these are the differences, and thank you.
Thank you, Dr. Shafkat. I would like to invite Professor Imran Akram Sahab for eyelid colobomas.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. So basically it's an absence of union between contagious tissues, and it's a failure of the mesoderm to fill the lid fold. Incidence is rare by as rate as 20%. Could be small, medium or large. Small is less than 25% and large greater than 40%. Full thickness defects as well as partial thickness defects, they are. So if there is a coloboma, there can be so many problems, mostly related to exposure. But there could be symbol from keratinization. In the upper lid, if the large coloboma, there is a levator defect and the fornix is absent. So the management starts right away. We have to protect the eyeball, covering it with petroleum gel or fluids. And there is a Sahab wet chamber. This is created by, this is a total coloboma. So what we do is we clean the eye, put in some ointment, and then put in a offside sheet that sticks there, and this creates a wet chamber. And so the eyeball is protected, as the eyeball remains wet and doesn't dry up. And because it is sticking, the child can't take it off. So we have been able to save many eyes. You keep putting ointments and drops, they keep rubbing it off, they fall off. So the wet chamber works like anything, and offside is present everywhere. So the main aim of treatment is to close the defect, and that is done in 3 layers. And so it's basically plastic surgeries. I define it as a knowledge of behavior of tissue used for benefit of the patient. You ought to know how the tissue behaves. Otherwise, you can't do a plastic surgery. So when you are doing a surgery, you have to see so many properties of the tissues. Its vascularity, its resilience. Sometimes the tissue is so soft, you put in the suture and cuts through. Fragility. So they all have to be kept in mind. Most important is the vascularity. The wounds in the face and eye, they heal very quickly because of better vascularity. So how to manage? We can do closure directly with canthrolysis and then lid shearing, and then we can rotate the lid. The closure is for small defects. You can just pull the lid across and join it to the, as you can see, the main important is that you have to raw the surfaces. You have to raw the surfaces, pass metal suture through firm tissue. We do a lot of stitching, and next way we see the wound is opened up because we didn't pass the stitch through the firm tissue. And the apposition has to be proper, alignment. So there you can see, this is basically defect. You can see that, and that's what it looks like. And what I did was, first I removed the partial thickness lid, created a raw surface, this one, all along the lid margin, and then we closed the lid. This is what is created, and then we just simply suture it up. The important sutures are the one near the lid margins, anchoring sutures between the tarsal plates. As you can see here, this is the most important suture, and if it is done properly, it sets a scaffold on which you can unite the rest of the lid. You can stitch the lid on it. So I'll keep going with tarsal plate, then muscle, then the skin. And this is how it looks like post-operatively. If it's a larger defect, then you have to release the lid from the lateral side. It's a cantholisis. Lateral palpebral ligament is cut and then upper crust is. So there you can see a very large defect, this one. So if you just pull the lid, it won't come. So you have to do a lateral cantholisis. Again, the procedure is the same, only that you do lateral canthotomy, cantholisis, and then you pull the lid and you see appropriate relief has been achieved so that the lid can be pulled closed. So this is the cantholisis. There we see that now we are able to close it. This is, well, one thing is important. This is the defect we have created, and there we have sutured it. If you see, this is very interesting. You can see the upper lid is very tight and the lower is now released. So here this is where it is important, you know, the behavior of the tissue. This lid is going to relax over the next few days. And there you can see it has got better. The same lid which was very tight has become better. Then there is a lid sharing process. If you have got a defect more than 40%, then we have to share the defect with the lower lid. So we have to measure the defect and I'll just show you. There's a large defect, and that's where I create a raw surface so that the lower lid flap can be stitched there. We take our flap from the lower lid. There you can see there's this gap has been decreased by the suture so that you can have a minimum gap. You don't have to put a very, this is the same very defect which looked very large, but once pulled together it becomes very small. So this is what we have to fill now. So there's an incision in the, उधर ये आता नहीं है जो मैं इधर कर रहा हूँ. No. ये कर्सर आता है इधर, नजर आता है. पॉइंटर है यार, गड़बड़ो तुम लोग, मैं ऐसे ही करता रहा. अच्छा नहीं भाई. सो इसको हमने जी वो सूचर कर दिया, इसको डिफेक्ट को छोटा कर दिया और यहाँ के इसका मैचिंग डिफेक्ट नीचे से मैचिंग इंसिशन दिया स्किन में, मसल में, कॉन्जंक्टिवा में. एंड दस ये जो फ्लैप है इट इज़ पुल्ड अंडर दिस ब्रिज, नीचे से ब्रिज निकाल के यहाँ पे हम ले आते हैं. जैसे ये नीचे से गुजार के इधर ले आए. एंड देन वी स्टिच, आई स्टिच इट इन 3 लेयर्स, कॉन्जंक्टिवा को, मसल को और स्किन को. एंड सम पीपल टेंड टू पुट इन अ कार्टिलेज फ्रॉम द ईयर. अगर बड़ा डिफेक्ट हो तो डालना पड़ता ताकि टार्सल प्लेट की भी सब्सटीट्यूशन हो जाए. एंड दिस इज़ हाउ इट लुक्स लाइक. आपको वो डिफेक्ट जो है वही वाला इतना बड़ा लग रहा था, अब इतना छोटा सा रह गया और बंद हो गया. नीचे से इसके ब्रिज के नीचे से ही जा रहा है फ्लैप. सो देयर यू सी दिस वन. अच्छा, इसको हमने बाद में खोलना भी होता है. ये नीचे से जा रहा, दिस इज़ द फाइनल पिक्चर. ये यहाँ पे हील हो जाएगा. बच्चों में जल्दी हो जाता है, बड़ों में हम ज़्यादा देर लेते हैं, मे बी अ मंथ. इसकी वैस्कुलरिटी जब इस्टेब्लिश हो जाती है फिर इसको हम यहाँ से सेपरेट कर देते हैं और इसको यहाँ पे बंद कर देते हैं. अब ये देखिए ना, आपको लगेगा ये लिड तो है लेकिन ये बंद हुआ हुआ है बिकॉज नीचे से फ्लैप जा रहा है. सो आई पास द प्रोब अंडर इट एंड यू कैन सी द प्रोब दूसरी तरफ निकल गई. दैट पास अंडर इट. इसको हमने अब वो करना है. तो इसमें एक चीज़ हमने करनी थी, वी कट द स्किन, देन वी कट द मसल, and when we go to the conjunctiva, we try to take extra conjunctiva from the lower side. Conjunctiva को उस लेवल पे नहीं काटते, फालतू काटते हैं, because this conjunctiva is supposed to be wrapped around above the raw surface. ٹھیک ہے نا جی, تاکہ لڈ مارجن جو ہے وہ اسکن سے نہ بنے, کانجنکٹیوا سے بنے. سو یہ ہم نے فالتو کانجنکٹیوا لے کے اس کے اوپر لگا دیا. سو یو کین سی اب کانجنکٹیوا کو الگ سے اسٹچ کر دیا. دس از ویری امپورٹنٹ, تاکہ یہ جو ہے بعد میں رب نہ کرے. سو دیٹس ہاؤ دا اپر لڈ پورا ہو گیا جی. اگر پورا لڈ ڈیفیکٹو ہو, then we go for a lid rotation technique. We know that it's the upper lid which is more important, rather importance the upper lid کی ہے because of movement and as well as because of covering of the eyeball. تو ہم اس لوور لڈ کو سیکریفائز کر دیتے ہیں اپر لڈ کے لیے. یہ ہمارا اتنا بڑا ڈیفیکٹ ہے یہ والا. سو لوور لڈ کو ہم روٹیٹ کر کے اس کے اندر ڈال دیں گے. سو دیر یو سی, اس میں ایک دو چیزیں امپورٹنٹ ہوتی ہیں. صرف لڈ روٹیشن امپورٹنٹ نہیں ہوتی. آپ دیکھیں دیر از نو فارنکس اور سارا کریٹینائزڈ ہے. سو جب آپ اس کو روٹیٹ کر رہے ہیں تو آپ نے اس کو بھی ساتھ بنانا ہے. میں کیا کرتا ہوں کہ اس کو اگر ایون اٹ از کریٹینائز تو اس کو را یہاں پہ کرتا ہوں تاکہ یہ لمبر اس کا کورڈ رہے. اس کو بعد میں بھی چینج کیا جا سکتا ہے. سو دیر یو کین سی اس میں ہم نے وہ سارٹ آف فارنکس بھی بنا لیا اور اس کو لے جا کے یہ انسیجن دیا. یہ دیکھیں یہ والا انسیجن یہ ایسے, اور اس نے اس طرح روٹیٹ کر کے اس نے یہاں جا لگنا ہے, اس نے یہاں لگنا ہے اور اس نے یہاں پہ آ جانا ہے. لائک دس, اس کو فکس کرتے ہیں. دین لیٹ دا بلڈ ویسلز گرو. ٹھیک ہے نا جی. اور اس میں وہی بات ہے, اگر ہمارے پاس تھوڑا سا بہتر ہو اسٹرکچر, اس میں تو نہیں تھے, تو ہم وی کین ایون لوکیٹ دا لیویٹر اینڈ یوز اٹ ان اے فیو کیسز, ناٹ آل. تو یہ اب اس نے یہیں پہ ہیل ہونا ہے اور اس کو بعد میں جب ہم کھولیں گے, دس از واٹ اٹ لکس لائک فائنلی. اب اس کو ہم تھوڑا اسٹریچ بھی کرتے ہیں, تھوڑا کھینچتے ہیں تاکہ یہ پورا اس طرح اس کو اپنے ڈیفیکٹ کو بھی کور کر لے, اس کو بھی کور کر لے. اور پھر اس کو ہم نے کھول دیا. اب آپ دیکھیں یہ ہمارا یہ لوڈ روٹیٹ ہو کے اوپر چلا گیا, وہ بھی بن گیا, وہ بھی بن گیا, اور جو ہے فارنسز بھی ہیں تھوڑے سے. تو دس از کنسٹرکشن. اچھا, سو اگین آئی ووڈ سے پلاسٹک سرجری از نالج آف ٹیشو بیہیویئر یوز ٹو آر ایڈوانٹیج. اس میں وہ سارے باتیں ہمیں پتہ ہونی چاہیے. وہی دوبارہ میں ریپیٹ کر رہا, اسٹرکچر, ویسکولیرٹی, ہیلنگ, سب کچھ ہمیں پتہ ہونا چاہیے. ٹھیک ہے نا. اور تب جو ہے وی کین میک یوز آف اٹ. کتنی اس میں اسٹریچیبلٹی ہے, کتنی الاسٹیسٹی ہے, کتنی اس میں اسٹرینتھ ہے, اور ساری پتہ ہوگی تو اس کو ہم یوز کر سکتے ہیں. بٹ ایٹ دی اینڈ دس آل بوائلز ڈاؤن ٹو ہارڈ ورک, پرسیویئرنس. آپ کو ملٹیپل پروسیجر کرنے پڑتے ہیں, مریض کی بات سننی پڑتی ہے, کافی سخت جان بننا پڑتا ہے. بٹ اٹس آل بوائلز ڈاؤن ٹو ہارڈ ورک اینڈ پرسیویئرنس. تھینک یو جی.
Thank you very much, Professor Sahab. Now there is a time for question and answer. We haven't got time, but I mean, there is no further presentation here. So, Fahad Kamal Akbar, isn't it? You will run the session of the questions. So difficult question کریں تاکہ جواب دیں.
سر جواب مجھے بھی کوئی نہیں آنا جو بڑے ہیں. اینی کویسچن فرام دا آڈینس فار دا اسپیکر؟
In a child with coloboma, I mean, do you wait a certain time or do it as early as possible?
As early as possible.
As early as possible.
آپ جلدی کرنا چاہیں کر سکتی ہیں. پہلے یہی پرابلم تھا کہ اگر مریض جو ہے پری میچور ہے, آپ کچھ کر نہیں سکتے, آنکھ کھلی پڑی ہے, اب آئنٹمنٹ ڈال رہے ہیں, آئنٹمنٹ ایک طرف چلا گیا, پانی ڈال رہے ہیں, پانی ایک طرف چلا گیا. مینی پیشنٹ اینڈیڈ اپ ان کارنیال السر, ایبسیسز اینڈ پینوپٹلمائٹس. تو یہ آئیڈیا ہمیں آیا کہ ہم ویٹ چیمبر کیوں نہ بنا دیں. یہ ویٹ چیمبر کا آئیڈیا مجھے کہاں سے آیا کہ ہم چھوٹے تھے تو سری لنکا آتی تھیں, وہ چھوٹی بوٹل میں آتی تھیں, پوری آنکھ ہوتی تھی, اور ایسے انہوں نے اس کے اندر لگائی ہوتی تھی اسٹینڈ میں, لیکن ایک سویب پانی کا انہوں نے نیچے پھینکا ہوتا تھا. سو اس میں وہ سارا سیچوریٹ ہو گیا, اس کے اندر جو ایئر ہے. سو دا کارنیا ڈزنٹ گیٹ ڈرائی. ویٹ چیمبر. سو ویٹ چیمبر کیا کہ کلوز اسپیس ہے جس میں جتنا پانی باہر نکل رہا ہے اتنا اندر جا رہا ہے, تو ڈرائی تو نہیں ہوگا. سو ہم نے کہا کہ اس میں ویٹ چیمبر کیسے بنائیں. وہ گوگلز لگا رہی ہے, جب آف سائڈ ہے یہ چپک جاتی ہے, 2-3 دن آرام سے نکال لیتی ہے. ٹھیک ہے. اس کے بعد دوبارہ سے اس کو ہٹا کے آپ دوبارہ آئنٹمنٹ ڈال کے دوبارہ, تاکہ اینٹی بایوٹک بھی رہے اور وہ کور بھی رہے اور بند. ٹھیک ہے. اس میں آنکھ ڈرائی نہیں ہوتی. ہاں, اس کو ہم بہت اور بڑی جگہوں پہ ہم نے یوز کیا. موربنڈ پیشنٹس ان میڈیکل وارڈ, نیورو سرجری میں ہم نے بہت یوز کیا. جنرل ہاسپٹل ہمارے بچے جاتے تھے, ان کو لگا کے آ جاتے تھے, ایکسیڈنٹس والوں کو, بیہوش لوگوں کو. ٹھیک ہے. تو ویٹ چیمبر وہ آپ کو ویٹ کرنا ہے تو پھر تو آپ کو اس کو پروٹیکٹ کرنا پڑے گا. ٹھیک ہے نا. ہاں, بہت سارے بچے. کیا چیز؟ ہاں 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 بیٹے, جتنا کھینچ تان کے اس وقت بن جاتا ہے وہ تو بنا لیتے ہیں, لیکن یو لیو ایوری تھنگ فار دا نیکسٹ سیشن, نیکسٹ سرجریز. ٹھیک ہے نا. ساری چیزیں ایک ساتھ ہو نہیں سکتی ایک وقت میں, اٹس ناٹ پاسبل. باقی ایمنیوٹک ممبرین سے تھوڑا سا ہمارا کانسیپٹ ٹھیک نہیں ہے کہ وہ کیسے کام کرتی ہے. کل ہمارا فارنکس فارمیشن پہ ہے, آئی ول ٹاک اباؤٹ اٹ, کہ ہم نے ممبرین سے ہم نے کیسے بنانا.
I would prefer rather buccal mucosa than the amniotic membrane.
جی سر.
In such cases. And I would just like to add, because we are getting on one side conjunctiva, so most of the time it's not needed. If you get one side, I mean you are doing rotation flap, so you get one side conjunctiva and the other raw side, you just do undermining and decrease the defect. There's a very little chance if one side is there covered, then that will be covered with epithelium. So you don't, most of the time you don't need, even if it is needed later on, you can use buccal mucosa, then amniotic membrane. Amniotic membrane will fall down. Mucosa will stick there. The second thing is about you asked about the age. So when the patient is fit for anesthesia, 2 दिन का कि 10 दिन का, because eye is in danger. اور besides that جو صاحب کہتے ہیں اس کے علاوہ یہ جو swimming goggles ہوتے ہیں نا, they are very good. They can make very good moist chambers. Usually میں severe dry eyes میں جن کو میں نے وہ کیا ایڈوائز کے, they are very happy people. کوئی اس پہ نظر بھی آتا ہے. That another way of doing the saving these.
اصل میں بچوں میں swimming goggle اور یہ لگتے نہیں ہیں,
یہ ملتے ہیں اور they are very useful. I don't know about the infants. مگر چھوٹے والے بھی. I mean these are the alternatives.
Alternatives ہیں بالکل.
Okay. Any other question? So thank you very much. I would like to thank all there are so many کہ اب میں نام نہیں لوں گا, سب کے باری باری. شفقت اللہ especially یہ بردان سے especially ہے, so I appreciate him a lot, and we'll see many more young people to come here and join us. Unfortunately audience were very few. I'm surprised. ورنہ ہمارے اس میں ہوتے ہیں ادھر زیادہ تر اسپیکرز ہی تھے. چلو کم از کم ہال اسپیکرز ہی فل کر دیا. And see you now, there is a plenary session. Whoever want to go and listen to them, they can head to the opposite, I think it's in the Crystal Hall. So thank you very much.